Welcome to the Deep Dive. Today we're tackling a really important topic, Hashimoto's thyroiditis, also known as chronic autoimmune thyroiditis. Think of this as your shortcut to understanding it inside and out.
That's right. Whether you're studying, maybe prepping for an exam, or just want to get a solid grasp on thyroid health, we're going to break down Hashimoto's.
Into the most crucial pieces.
Exactly. Our mission today is to give you a really high-yield understanding, something that sticks.
Perfect. And we've pulled the key info from, reliable sources like Medscape, Merck Manual, focusing on what's most important for you to know.
Good stuff.
Okay, so let's dive in. What exactly is Hashimoto's in simple terms?
Well, at its heart, Hashimoto's is an autoimmune disorder. Now, what does autoimmune mean? It's like your body's defense system.
The immune system.
Yeah, the immune system, which is supposed to protect you from things like infections. Well, it gets confused. It starts attacking a part of your own body.
Okay.
And in this case, it's the thyroid gland. So this attack causes ongoing inflammation there.
So it's like a case of friendly fire, sort of, on the thyroid gland. And what's the main result of all this inflammation?
The big outcome is hypothyroidism.
Right, an underactive thyroid.
Exactly. As the immune system keeps attacking the thyroid tissue, the gland becomes less and less able to produce the thyroid hormones your body needs. In fact, Hashimoto's is actually the most common reason why people develop hyperthyroidism.
Now, okay, so the most common cause. That makes sense. The body's own defenses causing the problem. Are there any, specific clues in the blood that tell us this is what's happening?
Yes, there are. Often we find specific proteins called autoantibodies in the blood.
Autoantibodies.
Yeah, think of them as markers of this mistaken attack. The main ones to remember are anti-thyroid peroxidase, or anti-TPO for short,
Anti-TPO.
and anti-thyroglobulin. Sometimes we also see TSH receptor-blocking antibodies. Finding these really helps confirm that the immune system is targeting the thyroid.
Okay, so these antibodies are like little flags saying, autoimmune attack here. Now, I remember reading this affects more women than men. Is that right?
Absolutely. It's significantly more common in women. We're talking about 10 times more frequent than in men.
10 times. Wow.
Yeah, it's a pattern we see with quite a few autoimmune disorders, though, the exact reasons for this gender difference are still being figured out.
Interesting. So what actually starts this whole thing? What are the initial sparks, that cause the immune system to go after the thyroid like that?
The causes, or what we call the etiology, it's usually a mix of things.
Not just one thing.
Generally not just one single factor, no. It's more like a combination of your genes and certain things in your environment sort of working together.
Okay.
Think of it like needing both the right kindling, the genetic predisposition, and then a spark from the environment to start the fire.
So there's a genetic piece to it, like it can run in families.
Yes, definitely. Certain genes, especially those within what's called the HLA system.
HLA gene.
Yeah, you can think of this as a set of genes that help the body tell its own cells from foreign invaders. Well, specific HLA genes have been linked to a higher risk of developing Hashimoto's.
So family history matters.
It does. If someone in your family has it, your risk might be a bit higher.
And you mentioned environmental factors. What kind of things around us could potentially trigger Hashimoto's in someone who's already predisposed?
Well, several things have been suggested as potential triggers. These could include viral infections.
Like just a regular virus?
Could be, yeah. Like a common cold that just happens to set things off in someone who's genetically susceptible. Also, too much iodine exposure.
Iodine. How would that happen?
Sometimes from supplements or certain medications, and even certain drugs themselves have been implicated as potential triggers.
Okay, so it's a combination of what we inherit and what we're exposed to. So linking into that, are there specific things that might make someone more susceptible? The risk factors, basically.
Exactly, risk factors. And one of the big ones is having a family history of autoimmune disorders in general.
Not just Hashimoto's.
No, if you have relatives with conditions like lupus, rheumatoid arthritis, or other autoimmune thyroid problems, you're at a higher risk for Hashimoto's too.
And the fact that it's so much more common in women, that itself is a risk factor, isn't it?
Yes, absolutely. Being female is a significant risk factor, partly because autoimmune diseases generally are just more prevalent in women.
Right. What if someone already has another autoimmune condition, say type 1 diabetes? Does that bump up their risk for Hashimoto's?
It does, yeah. If you have one autoimmune disease, your immune system is already kind of prone to misfiring. So your risk of developing another one, including Hashimoto's, definitely goes up.
Okay.
We often see Hashimoto's alongside conditions like type 1 diabetes and also celiac disease.
It sounds like once the immune system starts down that path, it might target other areas too. And those environmental triggers we just talked about, viruses, iodine, they kind of double as risk factors as well.
Precisely. Things like a history of certain viral infections or maybe living in an area with very high iodine intake could increase the likelihood of Hashimoto's developing, especially in someone who's already genetically susceptible.
Right.
And of course, going back to our genes, those specific HLA genes we mentioned earlier really put genetics firmly in the category of a key risk factor.
Okay, that paints a clear picture of who might be more at risk. Now let's get into the nitty-gritty of what's actually happening inside the thyroid gland. The pathophysiology.
Right. So in Hashimoto's, the immune system launches this direct ongoing attack on the thyroid gland itself.
Okay.
This involves different types of immune cells, various inflammatory processes, and it all ultimately leads to damage and, well, destruction of the thyroid tissue.
And that damage is what stops the thyroid from making enough hormone.
Exactly that. As the thyroid cells get damaged and die off, the gland's ability to produce enough thyroid hormones, mainly T4 and T3, which you need for energy, metabolism, all sorts of things, that ability is reduced, and that leads to the hypothyroidism.
And those autoantibodies we mentioned, anti-TPO, anti-thyroglobulin, what are they actually doing in this destruction process?
Well, the exact mechanisms are still being fully worked out, but we know these autoantibodies are involved in the damage.
How so?
They can contribute to the inflammation, help destroy the thyroid cells, and just further impair how well the thyroid can actually function.
It sounds like a real long-term battle happening inside the gland. How does this stack up against something like Graves' disease? People hear about that one too.
That's a really great point to clarify, because while both Hashimoto's and Graves' are autoimmune thyroid disorders, they do kind of the opposite thing to thyroid function.
Opposite.
Yeah. In Graves' disease, the immune system makes antibodies that actually stimulate the thyroid. They push it to work harder, often leading to hyperthyroidism and overactive thyroid.
Oh, okay.
But in Hashimoto's, like we've been saying, the immune attack destroys thyroid cells, leading to hypothyroidism. So yeah, they're really two sides of the same autoimmune thyroid coin in a way.
That's a super helpful distinction. Stimulate versus destroy.
Got it. Now, we mentioned environmental factors as triggers. Do they also affect how the disease progresses over time?
They're thought to, yes. For example, iodine intake, interestingly, both too little and too much can potentially worsen autoimmune thyroid disease in people who are susceptible. And similarly, things like certain medications, maybe ongoing infections, smoking, even dietary factors, they're all being studied for their potential impact on how Hashimoto's develops and progresses.
And you mentioned TSH receptor blocking antibodies earlier, too. How do they fit into the damage picture?
Right. So in some people with Hashimoto's, the immune system produces antibodies that don't just attack the tissue, they actually block the TSH receptor.
The receptor for the signal from the brain.
Exactly. TSH, thyroid-stimulating hormone, that's the signal from the pituitary gland in the brain telling the thyroid to make hormones. If that signal gets blocked by these antibodies, it just further hinders the thyroid's ability to produce T4 and T3, makes the hypothyroidism worse. Interesting. So multiple ways the immune system interferes. Now, when the thyroid cells are first being damaged, does anything happen with hormone levels right away?
Yes, sometimes. In the very early stages, as those thyroid cells are getting injured, they might actually leak some of their stored T4 and T3 out into the bloodstream.
So a sudden release.
Kind of. And this can sometimes lead to a temporary, usually mild period of hyperthyroidism before the overall trend towards hypothyroidism takes over.
So you might feel sped up initially.
Potentially, yeah. It's not always noticeable, but it can happen. It's sometimes called Hashitoxicosis.
Hashitoxicosis, okay. And I think you mentioned something about a Goitre's form links to a specific gene.
Yes, that's right. The presence of a specific genetic marker, HLA-DR5, has been associated with the form of Hashimoto's that typically involves a goiter.
Which is just an enlarged thyroid gland.
Exactly, an enlargement of the thyroid gland. So some people with Hashimoto's will have that noticeable swelling in their neck, the goiter.
And finally, just circling back to that strong genetic link, how significant is the role of our genes overall in this?
It seems very significant. Studies looking at identical twins have shown a really high rate of both twins developing autoimmune thyroid disease if one has it.
Really high.
Yeah, the estimates for heritability are around 70%, which suggests that about 70% of the risk of developing autoimmune thyroid disease is likely down to the genes we inherit.
Wow, 70%. That's substantial. Yeah. Okay, so we've got a handle on what Hashimoto's is and how it develops. Now, if someone comes in with symptoms that might be Hashimoto's, what else do we need to rule out? What's on the differential diagnosis list?
That's a crucial step, absolutely. When someone has symptoms of an underactive thyroid, we definitely need to think about other possible causes.
What?
Well, there's primary atrophic hypothyroidism. That's another form where the thyroid gland shrinks, but maybe without a noticeable goiter. We also have to consider hypothyroidism that happens after thyroid surgery.
Right, if part of the gland is removed.
Exactly. Or after radioactive iodine treatment, which is often used for conditions like Graves'. And of course, in newborns, we always screen for congenital hypothyroidism, where the thyroid isn't working right from birth.
Okay. And what if the main thing someone notices is a swelling in their neck, the goiter, or maybe doctors find lumps, nodules in their thyroid? Could that be something else entirely?
Yes, absolutely. If there's a goiter, we need to differentiate Hashimoto's from other things that cause thyroid enlargement, like maybe iodine deficiency, though that's less common now in many parts of the world. And we absolutely need to evaluate any thyroid nodules carefully. They could be benign, just harmless lumps, or in rarer cases, they could be malignant, meaning cancerous.
So getting the right diagnosis there is obviously key.
Hugely important, yeah, because the management can be quite different.
And since Hashimoto's is autoimmune, are there other autoimmune conditions that might look similar at first or have overlapping features?
Definitely. In the early stages, especially if someone has that transient hyperthyroid phase, it could potentially overlap a bit with Graves' disease symptomatically.
Okay.
We also need to think about subacute thyroiditis. That's an inflammation of the thyroid, often temporary, maybe after a virus, which can also cause changes in thyroid hormone levels and sometimes neck pain.
Right. And you mentioned earlier that Hashimoto's often travels with other autoimmune conditions. Is it important to keep those in mind during diagnosis?
Absolutely. While those other conditions don't necessarily mimic Hashimoto's directly, finding one should definitely raise your suspicion for others, including Hashimoto's, because they cluster together.
They seem to run in packs sometimes.
They really do. Hashimoto's and hypothyroidism have been linked with quite a few others, just to give you a flavor. Addison's disease, type 1 diabetes, hypogonadism, hypoparathyroidism, pernicious anemia, alopecia areata,
Wow, okay.
chronic active hepatitis, polymyalgia rheumatica, or giant cell arteritis, primary biliary cirrhosis, rheumatoid arthritis, Sjogren's syndrome, SLE, lupus, scleroderma, vitiligo. It's quite a list.
It really is. It just shows how interconnected these immune issues can be. And you also mentioned a possible link to cancer. That's something important to consider too, I guess.
Yes, it's not a huge risk, but the long-term inflammation from Hashimoto's is linked to a slightly increased risk of papillary thyroid cancer.
Which is the most common type.
It is, yes. So while the overall risk is still relatively low, it's definitely on the radar, and it's another reason why thyroid nodules found in people with Hashimoto's are usually investigated.
Okay, good to know. Let's step back a bit and look at the bigger picture. How common is Hashimoto's out there in the population? What are the epidemiology basics?
Well, as we've hinted, Hashimoto's is actually pretty common.
Right, the leading cause of hypothyroidism.
Exactly. It's a leading cause worldwide and definitely one of the more frequent autoimmune disorders that we see.
And overwhelmingly more common in women, we said.
That's correct. Women are affected far more often than men. And it typically shows up in middle age, although, it can occur at any point in life, really.
Do we have a rough idea of the prevalence? Like what percentage of people might actually have it?
Estimates vary a bit depending on the study and population, but generally it's thought to affect somewhere around 2 to 5% of the general population.
2 to 5%. That's actually quite a lot of people.
It is, yeah. Makes it a fairly common condition overall.
And that peak in middle-aged women, is there a typical age range where diagnoses cluster?
Yes, it's often diagnosed in women between the ages of, say, 30 and 50.
Okay.
This period seems to align with a higher overall incidence of many autoimmune diseases in women. And that ratio we mentioned, women to men, is often cited as being around 10 to 1, sometimes even higher.
10 to 1. Still staggering. And we've touched on this, but just to reinforce, Hashimoto's often doesn't travel alone, does it?
That's right. It frequently co-occurs with other autoimmune disorders. We commonly see it in people who also have conditions like Sjogren's syndrome, pernicious anemia, and celiac disease.
So finding one might prompt looking for the others.
Exactly. If someone has one of these conditions, there's a higher chance they might also have or perhaps develop Hashimoto's down the line.
Okay. So someone might have this brewing for a while before they even realize it. What are the typical signs and symptoms that might eventually make them think, maybe I should see a doctor? What are the clinical features?
The way Hashimoto's presence can be really quite varied from person to person.
Making it tricky sometimes.
Can be, yeah, which sometimes makes it a bit hard to diagnose straight away. But the most common symptoms are definitely those that come with having an underactive thyroid, the hypothyroidism.
And we have that handy mnemonic for those, don't we? Let's share that again.
Yes, that's a great revision tool. The mnemonic fatigue C, it really covers the classics.
So F is for?
Fatigue, feeling extremely tired more than usual. Always cold. Cold intolerance, even when others feel warm. Thinning hair and also dry skin is very common.
Okay.
Increased weight, often gaining weight despite no real change in diet or activity.
Yeah.
Goitre, that enlarged thyroid gland might be present, that swelling in the neck.
Ew.
Underactive mood, maybe feeling low or depressed, and also underactive bowel, so constipation.
And C?
And finally, C for low energy, just that overall lack of energy.
Fatigue. See, that's brilliant.
Got it.
Fatigue, always cold, thinning hair, dry skin, increased weight, goiter, underactive mood, constipation, energy low. Covers a lot.
Yeah.
Anything else common?
Yes. Other things people often report include muscle aches and stiffness, maybe joint pain. Menstrual irregularities are common in women. And like the mnemonic says, constipation and just that general feeling of being drained. And yeah, some people will actually notice that swelling in the front of their neck, the goiter.
And we already talked about the link with other autoimmune diseases like type 1 diabetes and celiac.
Yeah.
Are there any other ways Hashimoto's might initially show up?
Well, it's worth remembering that small group of people who might initially go through that brief hyperthyroid phase.
Right, the Hashitoxicosis.
Exactly. So they might present with symptoms of an overactive thyroid first, which can be confusing, but that's usually temporary before the gland function declines.
So it could start with feeling wired before things slow right down.
Oh.
Good to keep in mind. What about when the hypothyroidism is more established, longer lasting? What physical signs might a doctor pick up on?
Yeah, in more established hypothyroidism, we might see physical signs like bradycardia.
Slower heart rate.
Yes, a slower than normal heart rate. And sometimes, maybe surprisingly, hypertension, high blood pressure can occur.
Oh, interesting.
Other potential findings include macroglossia, that's an enlarged tongue swelling in the arms and legs, which we call peripheral edema, definitely cold, dry skin, and often puffiness around the eyes, known as periorbital edema.
And in really severe untreated cases, it can get quite dangerous, can it?
Yes, absolutely. In extreme cases of long-standing, untreated hypothyroidism, a life-threatening condition called myxoedema coma can develop.
Myxoedema coma.
Yeah, it's a true medical emergency requiring immediate hospital treatment. High mortality rate, unfortunately.
Okay. And just quickly going back to that initial hyperthyroid phase,
Yeah.
if it happens, what would those symptoms look like?
Sure, if someone experiences that transient hyperthyroid phase, they might notice things like tachycardia, a rapid heart rate, maybe some unexplained weight loss, feeling restless, anxious, jittery, palpitations or a racing heart, excessive sweating, feeling hot all the time, heat intolerance, maybe some tremors or shaking, and changes in menstrual cycles as well.
And you mentioned the thyroid gland can get enlarged, the goiter. How might someone notice that? Can it cause problems itself?
Yeah, the goiter can develop in different ways. Sometimes it might enlarge relatively quickly, and in rare cases, if it gets really big, it could potentially cause compressive symptoms.
Like pressing on things.
Exactly, like difficulty breathing, which is dyspnoea, or difficulty swallowing, dysphagia if it's pressing on the windpipe or esophagus. More often, though, it develops gradually.
It might be linked to that initial mild hyperthyroidism phase.
Sometimes, yeah.
What happens to the thyroid gland itself in the long run with Hashimoto's? Does the goiter just stay there, or does it change?
Well, over time, that ongoing autoimmune attack can eventually lead to thyroid atrophy.
Atrophy meaning it shrinks.
Yes. The thyroid gland actually shrinks down in size. This is often more associated with the development of myxoedema, that severe form of hypothyroidism. So while a goiter can certainly be present, especially earlier on, the long-term trend for many is towards a smaller, less functional thyroid gland.
Okay, right. So a patient comes in, they've got some of these symptoms, maybe fatigue C is ringing true.
Hmm.
What investigations are we going to run to figure out if it is Hashimoto's?
Right. The diagnosis usually involves a combination of looking at the patient's symptoms, the clinical picture, and really importantly, doing specific blood tests.
What are the key blood tests we're looking at first?
Okay, so we'll typically measure the levels of the main thyroid hormones in the blood. Total free T4, that's thyroxine, and total free T3, triiodothyronine, and crucially, TSH, thyroid stimulating hormone.
And what pattern do we expect to see in Hashimoto's?
In primary hypothyroidism caused by Hashimoto's, the classic pattern is low levels of free T4 and maybe free T3.
Because the thyroid isn't making enough.
Exactly, and a high TSH level because the pituitary gland in the brain is sensing the low hormone levels and yelling louder, basically, trying to stimulate the failing thyroid to work harder.
So high TSH is the brain shouting.
Yeah, that.
And crucially, we'll also check for those autoantibodies we talked about, right?
Absolutely. That's key for confirming the autoimmune nature. We'll measure the levels of thyroid autoantibodies, specifically anti-thyroid peroxidase, anti-TPO antibodies, and anti-thyroglobulin antibodies.
And finding those high levels points strongly towards Hashimoto's.
Very strongly, yes. Finding elevated levels of these antibodies is a major piece of evidence for Hashimoto's. However, and this is a really important point for revision,
Okay.
up to 15% of people who genuinely have Hashimoto's might actually test negative for these antibodies.
Oh, really? So antibody-negative Hashimoto's exists?
It does. So the absence of antibodies doesn't completely rule it out if the clinical picture and the TSH-T4 levels fit.
That's a very important caveat. Good tip. What about imaging? Does something like a thyroid ultrasound help?
A thyroid ultrasound can be quite useful, yeah. It helps us see the size and the structure, the texture of the thyroid gland. It can also identify if there are any nodules present. In Hashimoto's, the ultrasound might show a sort of characteristic pattern of inflammation, maybe diffuse changes, altered echogenicity, as they say.
But it's not diagnostic on its own.
No, usually not definitive on its own. It's typically used alongside the blood tests to complete the picture.
And if that ultrasound does show nodules or something else unusual, what's the next step then?
In those cases, especially if a nodule looks suspicious on the ultrasound, a fine needle aspiration biopsy might be recommended.
Tell me about that.
It's a procedure where a very thin needle is used, guided by ultrasound usually, to take a small sample of cells from the nodule or the thyroid gland.
Okay.
Those cells are then sent off to be examined under a microscope by a pathologist. It's really important for evaluating nodules to rule out the small possibility of thyroid cancer.
Right, makes sense. You also mentioned histology earlier, looking at the tissue microscopically. When would we actually get that view?
Well, you'd typically only get a histological examination of thyroid tissue if a biopsy is performed, like we just discussed for nodules. Or perhaps if someone ends up having their thyroid surgically removed for another reason, like a very large goiter causing problems.
And what would the pathologist see that screams Hashimoto's?
Under the microscope, they'd look for characteristic features. Things like widespread infiltration of lymphocytes and plasma cells. Those are types of immune cells flooding the gland. They might see lymphoid follicles forming, damage to the basement membrane of the thyroid's own structures, and eventually signs of thyroid tissue shrinkage or atrophy.
Okay. And what about those other tests, like a radioactive iodine uptake scan? Are they routine for diagnosing Hashimoto's?
Not usually for the initial diagnosis of Hashimoto's itself, no. A radioactive iodine uptake and scan is more commonly used to investigate the function of thyroid nodules.
To see if they're hot or cold.
Exactly. To classify them as hot nodules, which are usually overactive and rarely cancerous, or cold nodules, which are underactive and have a slightly higher risk of being cancerous, cold nodules might then prompt that fine needle biopsy.
Got it. And any other tests sometimes needed?
Well, depending on the person, and if there are signs of complications from the hypothyroidism, other tests might be done. For example, a lipid panel to check cholesterol levels is common, as hypothyroidism can cause high cholesterol or hyperlipidemia.
Okay, so we've covered a lot. Definition, causes, risks, pathophysiology, differentials, epidemiology, symptoms, and investigations. Phew. Now, let's move on to what happens after diagnosis. How do we manage Hashimoto's?
Right. The main goal in managing Hashimoto's is pretty straightforward. We want to restore normal thyroid function, get those hormone levels back where they should be, and relieve any symptoms of hypothyroidism the person's experiencing.
And the primary way to do that is with medication, I assume.
Yes, absolutely. The cornerstone, the main treatment, is thyroid hormone replacement therapy, and the drug we use is levothyroxine.
Levothyroxine, that's synthetic T4, right?
Exactly. It's a man-made version of the main thyroid hormone, thyroxine, or T4.
And how do doctors figure out the right dose? Is it one size fits all?
Oh, definitely not. The starting dose is usually based on factors like the person's weight and how severe their hypothyroidism is. But then, and this is key, it needs to be carefully adjusted.
Adjusted based on?
Based on regular monitoring of their thyroid function tests, primarily the TSH level, the aim is to get that TSH level nicely within the normal reference range.
So it involves regular blood tests and checkups.
Absolutely. Regular medical follow-up with blood tests is essential to make sure the levothyroxine dose is optimal, not too high, not too low.
And are there times when someone might need to see a specialist?
Yes, definitely. If someone has a very large goiter, especially if it's causing symptoms or if they have thyroid nodules that are concerning or any compressive symptoms in the neck, a referral to an endocrinologist, that's the hormone specialist, or maybe even a thyroid surgeon might be necessary.
Okay. And managing any other autoimmune conditions they might have is important too.
Yes, definitely need to address the whole picture.
What about lifestyle stuff? Does diet or stress management play a direct role in managing Hashimoto's itself?
Well, while levothyroxine is the essential medical treatment, focusing on a generally healthy lifestyle, a balanced diet, managing stress can certainly contribute to a person's overall well-being when they're living with Hashimoto's.
But no magic diet cures it.
No, there's no specific diet that's been scientifically proven to reverse or cure Hashimoto's, despite what you might sometimes read online. But general healthy habits are always a good idea for anyone.
Good point. Let's just focus back on levothyroxine for a sec. What's it actually doing?
It's simply replacing the thyroid hormone that the person's own damaged thyroid gland isn't making enough of.
No.
The goal is to bring the levels of thyroid hormones in the blood back up to normal, which then helps alleviate all those symptoms of hypothyroidism. We talked about the fatigue, the cold intolerance, etc. It's usually taken as a pill once a day.
Are there situations where surgery might actually be the primary treatment, or at least considered, for Hashimoto's?
Surgery isn't the first-line treatment for the hypothyroidism itself, but yes, there are specific situations where thyroid surgery might be considered.
Such as if someone has a really large goiter that's causing significant problems like making it hard to breathe or swallow,
Or if a thyroid nodule is found to be cancerous or highly suspicious for cancer.
Right.
Also, in very rare cases of thyroid lymphoma developing within the Hashimoto's gland, and sometimes, though less commonly for cosmetic reasons, if a very large goiter is really bothersome to the person's appearance.
Okay. Now, for people taking levothyroxine, anything important they need to know? Side effects, interactions.
Yes, definitely some key points there. Firstly, it's really important how you take it. Usually best on an empty stomach, typically first thing in the morning, at least 30-60 minutes before breakfast or any other medications.
Why is that?
Because absorption can be affected by food and certain other things. One really important interaction to highlight is with iron tablets and also calcium supplements.
Oh, okay.
They can significantly reduce levothyroxine absorption, so they need to be taken several hours apart, usually at least 4 hours.
Good tip. What about side effects?
Side effects usually only happen if the dose is incorrect, typically if it's too high, essentially causing symptoms of hyperthyroidism.
Like feeling sped up again.
Exactly. Things like a rapid or irregular heartbeat, maybe palpitations, feeling anxious or shaky, difficulty sleeping, diarrhea, weight loss, maybe menstrual changes. If someone experiences those, they need to tell their doctor, as the dose probably needs adjusting downwards.
Makes sense. And for really specific situations like managing hypothyroidism during pregnancy, people should look for more detailed guidance, right?
Oh, absolutely. Managing thyroid disease in pregnancy is a whole specialized area with very specific targets and monitoring. So yes, definitely consult resources focused specifically on that if it's relevant.
Okay. So putting it all together, what's the overall outlook for someone diagnosed with Hashimoto's who gets treated? What's the prognosis generally like?
The prognosis for Hashimoto's is generally very good.
That's reassuring.
It really is. With proper management, especially consistent thyroid hormone replacement therapy with levothyroxine, most people can expect to live full, healthy, and productive lives.
And is it typically a lifelong treatment?
Yes. In the vast majority of cases, once the thyroid gland has failed due to Hashimoto's, lifelong treatment with levothyroxine is necessary to keep those thyroid hormone levels normal and keep symptoms at bay.
So those regular follow-up appointments and blood tests remain really crucial long-term.
Absolutely essential. Regular monitoring of thyroid function, usually TSH, allows the doctor to make sure the dose is still right because needs can sometimes change over time. And it's also important for keeping an eye out for any potential complications.
And with that right care, taking the medication properly, people can generally expect a normal quality of life.
Yes, that's definitely the expectation and the reality for most people. Appropriate care, sticking to the treatment plan, it allows individuals with Hashimoto's to lead very normal lives.
Now, here's something I've heard. Sometimes people's lab results might be technically normal, but they still don't feel quite right. Is that a recognized thing?
That is a very important point, and yes, it is recognized. While getting the TSH and other thyroid levels into the standard normal range is the biochemical goal, it's also crucial for doctors to listen carefully to their patients' persistent symptoms.
So normal isn't always optimal for everyone.
Exactly. Sometimes, even within that defined normal range, a small adjustment in the levothyroxine dose, maybe aiming for a TSH in a specific part of the range, or sometimes considering T3 treatment in very select cases, can make a significant difference in how someone feels. It requires careful individual assessment.
Good to know. Finally, let's touch on potential complications. What sort of things can arise from Hashimoto's or its treatment?
Okay, complications. Well, the most common issues directly related to the thyroid itself are the development or growth of a goiter and the formation of thyroid nodules.
Which need monitoring.
Yes, and as we mentioned, while it's not common, there is that slightly increased background risk of developing thyroid cancer, specifically papillary thyroid cancer, in the context of Hashimoto's.
Okay. What about from the hypothyroidism itself if it's not well managed?
Right. If hypothyroidism isn't properly treated or managed, it can lead to a whole range of metabolic disturbances. High cholesterol is a big one. It can affect heart function long term, and of course impact energy levels, mood, weight, and general quality of life.
And we mentioned those rare autoimmune associations earlier.
Yes, in some individuals, Hashimoto's might occur alongside other significant autoimmune conditions like type 1 diabetes or Addison's disease, which bring their own set of potential complications.
What about complications from the treatment itself? Can taking too much levothyroxine cause problems?
Yes, definitely. Over-replacement, meaning the dose is too high for too long, can lead to problems. It can cause bone loss, increasing the risk of osteoporosis and fractures over time, and it can increase the risk of heart problems, particularly atrial fibrillation, which is an irregular heart rhythm.
So getting the dose right is critical.
Absolutely critical. And conversely, undertreatment can lead to that hyperlipidemia, the high cholesterol. There are also rarer complications like Hashimoto's encephalopathy.
What's that?
It's a rare neurological condition associated with Hashimoto's, causing confusion, seizures, stroke-like episodes. Its exact link is complex, but it's recognized. And then the most severe complication of undertreatment is that myxoedema coma we discussed.
The life-threatening one.
Yes, the very severe, life-threatening form of hypothyroidism with a high mortality rate requires emergency treatment.
So it sounds like preventing these complications really boils down to good management, regular checks, and sticking with the treatment plan.
Exactly. Regular monitoring with blood tests, appropriate dose adjustments by the doctor based on those tests and the patient's symptoms, and importantly, the patient consistently taking their levothyroxine as prescribed. Those are the absolute keys to preventing or minimizing these potential complications.
Well, this has been an incredibly thorough, really useful deep dive into Hashimoto's thyroiditis. Just to quickly recap the absolute basics for everyone listening, it's a common autoimmune condition. It causes hypothyroidism, usually needs lifelong treatment with levothyroxine, but, and this is the key takeaway, generally has a very positive outlook with proper care.
Precisely. Well summarized. We really hope this has given you a clear, high-yield overview, perfect for revision or just for understanding this important condition better.
Absolutely. And if you are revising and looking for more in-depth materials, practice questions, really want to nail topics like this for your exams, be sure to check out passthemsra.com.
And freemsra.com as well for great resources.
Definitely check those out. Thanks so much for tuning in to the deep dive.
Thank you.
And maybe a final thought to leave you with. Thinking about Hashimoto's, this interplay between our genes and the environment. How might understanding these autoimmune mechanisms better in the future lead to maybe preventing or managing not just Hashimoto's, but other autoimmune conditions too? Something to ponder.